in the pelvis, yeah? And it acts like a little ring, yes? And the cervix. The portion vaginalis portion extends down into the vagina, yeah? And all of the ligaments are attached to this ring. And you see where it now supports the cervix, eh? And the uterus as consequently. Yeah?
Prof, do you know who is setting the final paper?
Prof. Labutian distributes the stations and the questions to all of us. The stations are not evenly distributed.
Oh, not the spotter, the paper, the final paper.
Oh. Sharky,
I'm ready now.
who sets the neuro paper? Labutian?
UG.
JP sets the multiple choice.
GP sets in Europe.
That's good for you guys. These are nice guys.
What about-
When they become in the head, you want to hear that the pass rate is 90% or more.
What's
And
up?
you know what, you can smile and say yes. By extension, you say, man, this man is an excellent tutor, you understand me?
Oh, do you know about the UG one though?
The UG is who? And who's the UG? And I hear that. Yes. Who says the UG paper now? Who says the UG?
What?
UG, genital urinary. Hospital.
Bro, yo, that's the worst answer they could have given.
That's why you have to come to our lectures and stuff. Because we have experience and we tell you the books we highlight.
Yo, it doesn't. No. The people at Obs and Gyno department. Wait, Prof, why is it that people who don't teach us are sitting the exam?
At the beginning of the semester, they are then assigned tutor responsible for setting the multiple choice. And the lab, they belong to that department. The anatomy is us guys. Understand? But Labutina says he's a nice guy for you guys, very nice guy. He does not realize that the university, especially the hospital in today's headline, you hear this, Rocky? The university is $40 billion in the debt.
Who do we owe?
40 billion, not million, you know.
Every year we take tuition, so I don't understand it.
It's been siphoned off, man.
That was the hospital.
That's the hospital.
What do you mean? The first thing that they're gonna cut is the doctor's salaries. Is our problem.
Cut salary and
They're
then make
gonna,
it work.
they're gonna affect they teach doctors up here, and it's gonna affect their teaching. That's why some of them don't come teach, you understand me?
Yeah.
Because they're busy, what they call roasting, doing their private cases outside. So, in pregnant women, venous thrombosis is not uncommon. You understand? Which fluid is more particular for venous thrombosis in you ladies when you get pregnant? Sagardner mentioned that there are 3 vascular syndromes in the abdomen and
Three. Median artery.
that's not the answer.
Bad question.
So which side rather? Is venous thrombosis more common in the lower limb?
Right.
Venous left? Not. You say right? Alright, that's good. What you said, Jordan?
I say right.
Which of us is it?
Numerically, democratically, you should be right, but democratically you're wrong. It's on the left side, the idiot is right. That's what the idiot is.
That was my next guess.
Yes, you are correct.
Yeah.
And Mr. Gardner told you why
My bad, my bad.
on the left side. That's how it was. anatomically, why is it more common on the left organ? He mentioned 3 days to you. You got that system to God for you. That might be too much.
No, man, you man.
You mentioned the median artery syndrome where the cilia comes compressed. And after you eat it, after you eat it, the flow to the stomach gets explored. And you get intestinal angina, not cardiac angina. And he mentioned another one related to the superior mesenteric and the aorta. That's right? The syndrome again. What is syndrome? Wilkie syndrome.
Congested, you know.
I'm coming to the third syndrome now, Mr. Gardner. You see, you guys do that, Mr. Gardner. So what is the May Turner? That's carotid and the May Turner syndrome. What is the May
Turner with an H.
What is the May Turner? I can't spell.
Turner, T-H-U-R-N-E-R.
You're right.
Turner.
Memory is good. It's the antibody proven. Memory is-
No, you can't put this plastic bag over that table for me.
So what
On
is
top
the
of
May
that
Turner
blue bag.
syndrome?
You guys come now, come. Come and don't be way down there because I'm going to have to turn this way. I want to. You want to come, man. What you want is quality. What you want? Quality. Come. Yeah.
Right. Remember the vein is on the right side and the aorta is on the left side. So you can the right common iliac have to cross over, no? Because this is going to become the femoral, which is lateral to the vein. So, and the left common iliac comes out and it comes across to the vein. It has to cross all the way from the left to the right. Understand? So it must pass in relation to this common iliac artery.
Sorry.
You can either pass behind it or over it. But if you look underneath it, it's over it.
All right, guys. You did it many times.
So that's the May Turner. Plus when they get pregnant, the commonest position is for the baby head back, what they call left occipital anterior. The baby, you know when it's when the head go down, and the occipital is resting on the left side. Here is the tax. When you have Alright, so just freelancing. And you guys have to ask each other these things, you know?
Yeah,
You
definitely.
did not proper effect on Patrick.
I mentioned it to them, but I didn't go into detail because we're not going to ask you that.
Right,
I understand.
but very interesting is when the left renal vein, which is rare, decides now to go posterior to the aorta. That's not a good story at all. You're going to compromise. Yes, sir. You're going to. No, I don't even need it. No, sister.
No, you don't need it.
I don't need it.
Just the camera.
Just the camera. Yeah. You hear me? Don't you hear me well? Or just you guys come closer, come closer. So, a lot of you were not here for the male reproductive system, right? Now, in this case, very interesting is if you don't understand the male reproductive system, male external, the perineum. If you don't understand the perineum of the male, it's a dead story with the female. Okay? It's a dead story with the female. So therefore, and you see that we have an assortment of things on the table, that Crystal, you're going to use a lot. So you're going to start off. We're just having fun there. So you can see now that there are some different sizes of duckbill, forceps, speculums, duckbill, speculum, vaginal speculums, right? So you're going to do coulodoscopy.
They're going to look at the cervix.
You're going to look, yes. So in there is called the couldos. So you're going to have your light shining and you're going to be looking up at the cervix. So you're going to be examining in the vagina, but especially the cervix. The cervix is the big point of attention. And you can see that there are different sizes. This is called a duckbill, right, Patrick? The duckbill speculum, right? And you see that they will come in various sizes, okay? You see that there? And then now you have to know how to, so you're going to, all of you guys will use these regularly, and maybe some of you will have a practice. And my wife, she has a whole pile of them, okay? Duckbill speculums, and every morning they have to be what? To be? Autoclave, they Patrick? Autoclave, they're autoclave, a lot of them. And then a lot of the females, just as our males have to come in and get our prostate checked, then the females, you know, if they really examine them properly, then they will have to do an examination of the cervix and pap smear. Okay, so many of the women, a common thing is just regular thing is to do a pap smear. We have to get our prostates checked, and the females when they come in. When last did you do a pap smear will be one of your questions, right? So you're going to examine in there, and you're going to do what's called a kuldoscopy from kuldos, right, Patrick? Vagina kuldos, okay? Then there, and you can see there is specimens. And then you'll have some guys, you know, who will, you know, when they're very young days, go on and get, you know, gonorrhea. Okay, so you'll see, when you go to the clinic there, you'll see 19-year-old guys, 19 years old, and they have strictures of the urethra, right? So gonorrheas will cause all kind of fibrosis inside their urethra, right? And then now you're going to have to pass a bougie, right? So hold the thing. Yes, you're going to have to pass the thing, right, Patrick? Right? And you're going to have to dilate your urethra. Okay, and you have Dr. Barnett was showing you how you go in like this, and then you do a little turn around, and then you go back, and then you turn. So Dr. Ladenqui knows how to do that by heart, okay? Boom, so they go, the navicular fossa is here, so they have to go in, and then you go down, and then they come around like that, and then they're all up.
When you put it in first in the urethra.
The urethra, right.
Yeah, like the penis in the hand, you know, you clean up the glands. You have to point the thing in what you would think, the wrong direction as you enter the urethra meatus, right? Remember the vertical, slit the urethra. And you have to point it down, not up, because you know it's going up, not it? The urethra, going to the prostate eventually. But you have to point it down, like that. And you know the reason why I love. As I say, we need to, it's nice and tricky, and you know, but you need to understand why it has to be directed downwards. Got three, now got three in here. Why?
As to not damage something.
Yes.
What is this? Right in the fossa there, you know?
Is it like a gland?
No, man. The navicular fossa. Right, we were going to show you that. We're going to show it.
You're going to show
so watch when you're going now.
So there are some little pockets, as it were, in bracket. What do you call those again? In the navicular fossa.
Yeah, the navicular fossa.
Yeah. Okay. And if you had passed it that way, there's a possibility that you can end up in a
It's blind, yeah.
because dead end fossa, these sacs, you know? And as you pass it, then you'll make a false passage. You rupture the urethra. So you have to direct the tip of this dilator away from the navicular fossa at the top.
Away.
And having bypassed it, then you can now twirl it around, having bypassed it, you understand? And pass it as you imagine the urethra should be. But that is the reason you always say,
Yes.
oops, as we say.
And you don't start with one this size at all, you know.
No, not this size.
You have to go through a whole degrees of sizes, right? Something small. Yeah,
Not
then
so small either. There's one they call 710.
Then
There's
you
a
have to
French-
go through some
French
small
gauge.
one. Alright. Alright, so let's look right down here now. So we're just reviewing, okay? So we're going to do a quick 10-minute review, 5-minute review. So what are we looking at here? Can this fill up the page, okay? Yeah, it does. Just come in even more and fill it up more. Yeah, fill it up more. But you have to tell me, you know, I can't look behind me. Reasonable? Yeah. So if you, whenever I'm showing you something you want to, it fills up the whole screen. All right, Pete? So what we're looking at here, anybody has an idea what we're looking at here?
Prostatic
The
urethra.
prostatic urethra. Okay? So the prostatic urethra, very important. So the male urethra, if the female is very short, 4 centimeters, come a little closer here, 4 centimeters, the female is 4, reasonable, and the male is far longer. The male has a prostatic part, a membranous part, and a penile part. Okay? We're examining in the prostatic urethra. Okay? And we see that centrally going down is what is referred to as a urethral crest. Okay? And the urethral crest here is going to become like a rounded elevation. Okay? And that is called a verumontanum. Okay? That's the verumontanum. Okay? And that verumontanum now will have a little cul-de-sac. It's like the little female vagina, and that is referred to as the utricle. Below that now we will see opening the ejaculatory ducts. Okay? Remember that on the base of the urinary bladder is SUV. The vas will form what is referred to as the ampulla of the vas, and the ampulla of vas is going to join the semiduct of the seminal vesicle to form now the what? The ejaculatory duct. Isn't that so? So the vas deferens forms the ampulla of the vas. That's going to join this duct, the seminal duct, to form the ejaculatory duct. And the ejaculatory duct is going to open just a little below the utricle. Now, on either side of the urethral crest, so there's a mountain like a vertebral column going up and down it. On either side now will be what is referred to as a prostatic sinus. So there will be sinuses on each side, okay? And into these sinuses here will open the glands. Some glands are mucosal, some are more submucosal, some are peripheral, okay? Peripheral. So there's what's called a peripheral zone, there's a transitional zone, there's the anterior zone. So that anterior zone is going to be mainly what? Fibromuscular, right? However, there's been done some research on the Jamaican population and finding out there that there's a little few anomalies there with what they thought was more just fibromuscular. There's the glands that are just surrounded, small with short little ducts, mucosal, some extending a little further. And then Dr. Ledenko was pointing out that a lot of research is coming out on them on the peripheral glands. And these peripheral glands are the bone found towards the posterior part of the prostate and laterally. Those are the glands that tend, when they become problematic, these are the ones that are becoming malignant. Okay? Dr. Ledenko was again finding out that they say where the drainage is poor, you're going to end up with problems. So they found that these, look carefully, Crystal, that these glands that are peripherally placed, they have ducts that descend and make a hairpin bend and then come back up. Okay? So the drainage, and where the drainage is poor, that's where we're going to end up with problem, when the gland can't drain properly. And Patrick, benign problems can become malignant problems, right? So the benign hypertrophy of the prostate, if it's left unattended to,
Probably more chronic prostatitis, right?
right, chronic prostatitis. And then what they found out, very interesting, because I was in a discussion with somebody yesterday, and you will see, very interesting, a prostate. So when we get hypertrophy of the prostate, either benign or malignant, okay? The benign one, however, can later on become malignant. However, the malignant one in Jamaicans, what we find is that there are two types of prostatic cancer, it seems. One that is progressing slowly, listen carefully, one that is progressing slowly, and then one that is very aggressive, right? Very, very aggressive. So in Jamaicans, and I've seen it with a number of my friends, right? There was one of my friends, very quickly he got this prostate cancer. And he was struck down with it, ended up in the hospital, and I went to see him. My wife went to see him and said, Mikey, look, you need to go, because she was good friends with me. You need to go and see so-and-so, And I acted on it fast, and I went to see the person. And when I went to see the person, I was shocked. It was like I saw a cadaver on a bed. It was horrible. And the man's whole pelvis was frozen. The malignancy in the pelvis was just took over the entire pelvis. And he had nephrostomy tubes. He couldn't pass his urine. So it coming out of his back. One of my students put him 2 nephrostomy tubes, right? And then on top of that, he couldn't pass any of his fecal matter, so he had to get a colostomy. Right? When I saw the man, I was shocked. He was my good friend. He used to work in anatomy. I used to talk with him all the time, and he's a big surgeon, right? He says, Michael, after recognizing, what is crawling up on the wall? Nothing was crawling up on the wall. So Dr. Thomas said, Dr. T, you better go and look for Dr. XYZ, because he's not looking good. Then now I see Roy T coming back down looking very disappointed. I said, Roy T, did you see Dr. XYZ? Michael, when I went, the bed was empty, dead. Right? And then my other good friend, similarly, he had a normal PSA. For 3 years, he never checked his PSA. You don't want a PSA like 10 or 7 or none of those things. You want it to be like 0 or 1 or 2. Okay? Maybe 3. Anyway, when the poor man went to see, he said, Mike, I'm passing urine in the night a lot. He was 70 years old. And then just now to retire. Beautiful home and everything. When I said, well, 3 years is Dr. Ledenko, he's a private practitioner, never checked his PSA. When he went to check, what was his PSA? 300. Right. Then they put him, they recommended a urologist. Urologist did everything for him. In 1 month, what was his PSA? 1,500. Yeah, then from 1,500 it went. They put him on a drug that cost $3,000 a month. Then it went to 3,000. When he died, PSA was 4,500. Unbelievable. Left the Milky Way and he got into another thing about it. Poor man. When I went to see my good friend, he became a little skeleton in the bed. And even just to move, I saw tears coming down. The pain that was in that, on morphine, pethidine, gabapentin, everything. Rough story. So the prostate is 2 types. So you have to examine the patient's prostate, and the patient has to take their PSA. So there we can see we're in the interior of the prostate. Very important. So as I said, a urethral crest. Then you will see now that area referred to as also the colliculus seminalis, right, Patrick? Or the verumontanum. And there you can see opening into it a blind cul-de-sac known as the utricle. And there you can see the ejaculatory ducts on the side. And as I said, the peripheral glands, they take a long route, of course, okay? Very interesting. No. Then they will always ask, so you'll see them doing an ultrasound of the prostate. And what you'll see them recording is the volume of the prostate. That's what they're going to do to calculate it. So the height of the prostate is normally what? 3 centimeters. Width is 4 centimeters. So cephalocaudal is 3 centimeters. Width is 4 centimeters. AP is 2 centimeters. Volume is 20 to 30 cc's. So you'll always see on the report the volume of the prostate, 20 to 30 cc's. Weight is 20 to 25 grams. When we get to a patient of, say, 60 years old, and he has benign prostatic hypertrophy, that 20 to 30 will raise to about 30 to 40, right? 30 to 40, okay? So you'll see when they do the ultrasound quickly, that you see them just putting in some figures like that, and you're going to calculate the volume of the prostate, okay? Right. Then now with the PSA, so. Then now we look at the prostatic urethra. So there we can see the urethra. Okay, prostatic urethra, the most dilatable part. Prostatic urethra, most length 3 to 4, width 1 to 1.5. Okay? Then we have another boy called the membranous urethra. right? That membranous urethra, we find it. Where is the membranous urethra? Guthrie, where is the membranous urethra found? Where is it found? Where is the membranous urethra found?
And then, yeah, the perineum.
Where is it found? Hmm?
Yes.
300 miles in the urogenital diaphragm. Okay? It's found in the urogenital diaphragm. See how the profile looks? So sorry, that's how the profile looks of the prostatic urethra with the crest and the sinuses. That's how the profile of the membranous urethra looks, because it has all of the muscle around it, the sphincter urethrae. So the length 1 centimeter to 1.5. The width, right, is just 8 to 9 millimeters. Penile urethra, we were having fun last time. Penile urethra can what? Vary a lot in length. Isn't that so? In fact, some of these may not even be working, right? Hell boy, right? So the penile urethra, the male organ can be quite long. You be careful here, Crystal. Right? Just be careful. You do your proper inspection before the wedding night, right? Okay, right? You don't want to get frightened out, right? So it can be now what? 15 to, average is about 15 centimeters, right? Remember, there's a bulb, and then continues onward, okay? 15 to 20, 22, but then now in some males it can really be like you're going from here to Portland Road, okay? Is that bad, right? Right. It does not, that patient does not have to see Dr. Long. No, that patient does not need to find a Dr. Short, right? So you can get some shortening done, right, reasonable? All right, but that's it. And there we can see the width. Just relax. No, we're looking inside the penile urethra, and we're looking now from posterior to anterior. We're looking at what? So we cut it and we're looking from posterior to anterior. And we will see, so that is the glands of the penis. That is a continuation of the corpus spongiosum. And then we can see that there is that little cul-de-sac. So when you pass the instrument, as Dr. Dedenquist, you never pass the instrument going in like this. You have to put the instrument going like that so that you don't end up in this little cul-de-sac here, and that is called the what? The navicular fossa. Then all along the penile urethra, this is why the male is going to get stricture of the urethra. He has a lot of paraurethral glands, the glands of Leterre, okay? So the females have glands of Skene, right? The females have glands of, the male has glands of Leterre. So all along there, we're going to, and I'm going to show you in the specimen, we will see that there are all of these little openings here for the urethral glands. So what's happening with gonorrhea, so and so and so. The males now, they get this, what they call it now? What they call it now, Patrick? When they're passing, what they get now? Discharge. Right, so the male now comes with a discharge and bearing, burning thing, right? A pussy-looking discharge, right? Then now he will get his antibiotics, but the antibiotics, no, he can't manage the cost of all of the antibiotics, so he will buy a few, and then no, he doesn't continue the course. Then these glands are, the infection there continues, and there's a lot of fibrosis, and then no, then they have to go now they get strictures, they can't pass their urine, so they have to go regularly every 6 months or so and get their urethra dilated. You'll find all young men of 19 years old up there in the urology clinic. Okay. Now, let us look at a couple pictures, okay? So let us focus here now. So we're blamming to it. Relax. Excellent. So what are we looking at? Where the topic is, this is our final session with you on an area called the pelvis. Yes or no? Yes. So we're looking at the lateral pelvic wall here. Where's my point? What did I do? Oh, here. So we're looking here at the lateral pelvic wall. Okay? Just relax. And there we can see that's the, what artery are we looking at here? What artery would this be? This would be the internal iliac. Okay? And you can see now it's dividing into an anterior division and a posterior division. And over here, that would be the external iliac. See the external iliac? Then we see now these are the nerves coming out. From L4 and L5, coming down from L4, L5 will be a strong trunk coming down called the lumbosacral trunk that Dr. Barnett asks in the exam every year. The lumbosacral trunk. Okay? That's the lumbosacral trunk. Then we'll see S1, S2, S3, S4, S5. Okay? And when we look now, we will observe the anterior division of the internal iliac. And just to highlight, when we look at the posterior division, we find there's the iliolumbar artery and the lateral sacral, and then that posterior division continues as what? As the superior gluteal artery, right? So passing here between L5 and S1, there's a superior gluteal artery. Now from that anterior division coming off here, we see a boy here called the umbilical artery. See this boy here? That's the umbilical artery. And that umbilical artery will give rise to what? What's that umbilical artery give rise to? Crystal, what does the umbilical artery give rise to, love? 300 marks, the superior vesicle. Right? And then it continues as what structure? That umbilical artery is going to continue as what structure? Yeah? What is going to continue as? It's going to continue as the what? The medial umbilical ligament. The medial umbilical ligament is going to raise up a fold, or the medial umbilical fold. Then this boy here is the obturator artery. See the obturator artery? See it right there? Yes or no? Yes? That's the obturator artery. And you can see it's going to the obturator canal right here. And we remember sometimes that artery now may communicate with a pubic branch of the inferior epigastric and form a structure known as the crown of death, the corona mortis. Okay? And that there you can see going with the obturator nerve. Okay? All right, then we can see other vessels coming off, like the inferior vesical artery will be coming off, the middle rectal artery will be coming off, and there we can see that it is basically going to give rise here now. So you see our middle rectal, by the way, is up here. There we can see it now giving rise to that that anterior division now sort of becomes terminal in terms of what are the two major branches, the anterior division. Right, it's going to become terminated as. You know that, Richard? You know what there? So it's going to be the pudendal artery and the inferior gluteal. So coming down, the two major last portions are the pudendal artery. See the pudendal artery right here? And then we see now the inferior gluteal. So the superior gluteal is from this boy here, the inferior gluteal is here, and this anterior branch is going to give rise to the visceral branches. This one is going to give rise to the parietal branches. And you observe clearly here, look right here. So that's the internal pudendal artery, and there you can see the pudendal nerve. And you're going to see that the nerve is crossing over a ligament. And that ligament there is referred to as the, so when we come and we look right here, if we zoom in right and fill up here, you can fill up right here. So we're looking on this. What am I holding in my hand? What is this that I'm holding? What is this called? Yeah, man. What is this that I'm holding here? What do you call this bone?
Pelvis.
Nope. What bone am I holding right here? This is the os coxae, right? This bone is called the what?
Os
Hold it. What are you holding?
The os
I didn't hear you.
The os
Os coxae, right, Patrick? And we will see yellow, and we will see here, right here, this. So this is a review session, okay? This is the obturator membrane. And there you can see the obturator canal. See there, right there, that's the obturator canal, that's the obturator membrane. On its outside, the obturator externus, on the inside, the obturator internus. Obturator artery is going to come out through here, and give an anterior and a posterior branch that's going to form a circular anastomosis. Okay? And then, yes, we can. Right? So there we can see, then watch. We see a ligament here. What's the name of that ligament? I want you to enjoy yourselves, you know, look down on it, and we're here around in front. What ligament is this called? That's the pectineal ligament. Right? This is the pectineal ligament, okay? Or named after who? Cooper. The ligament of Cooper, Astley Cooper. Right? That's the ligament of Astley Cooper. Right. Then we're coming around here now, and we see that this is the greater sciatic foramen, and that's the lesser sciatic foramen. And the greater sciatic notch and lesser sciatic notch are separated by the ischial spine. Okay, the ischial spine. That's an important landmark. And then now we will see that structures are going to come out. We see two ligaments here. We see a ligament spanning between the sacrum and the ischial tuberosity. Rub your finger along that, Crystal. Just rub your finger along it. That will be the sacrotuberous ligament. Then you're going to see a ligament right here. ONG people are going to, once you leave here, you know, you're gone now, maybe you get a little minor break, then the ONG people are going to take you over hard, right, for another 15 marks. And they will be hard on you, okay? So these things you must know. And there we're going to see, watch here, and that is the sacrospinous ligament. So there's a sacrospinous and a sacrotuberous. So you will find now that, look here now, that the pudendal nerve is passing over the sacrospinous, just blow him up right here, the sacrospinous ligament. That's the pudendal nerve, S234. And there we see the internal pudendal artery. Now once these guys have crossed over, where are they now going to go? So once they're leaving and they're coming out, they're re-entering the lesser sciatic foramen. So they're exiting the greater sciatic foramen and re-entering now the lesser. So where are they now? Where's their next? What's the next plane? That is a one train. See, they're jumping on one train, onto another train, onto another train. Okay, so the train here was to leave through the greater sciatic foramen, exiting below the piriformis muscle, and then now they wind around in relation to the ischial spine. Okay? Right? And then after that, they have to jump off of that train and get on to the next train. What's the next train they get on to? Alcock's Canal. They're going to travel in the pudendal canal. Right? See them here in the pudendal canal, which is in the pudendal canal. We're just having fun, you know, which is in the lateral wall of the ischorectal fossa. They are really heading, their destination is the perineum. So they leave through the greater sciatic foramen, re-enter the lesser sciatic foramen, jump off of that train, quickly board another train, which is the what? Which is the Alcock's Canal, or the pudendal canal, right? And see the pudendal canal right here? Let's look right at the lateral wall of the ischorectal fossa. See the pudendal canal? Then after they leave the pudendal canal, they have to jump off of that train and jump into another train. What is the next train they jump into? The urogenital diaphragm, okay? And we're going to show you on the specimens where they actually go into the urogenital diaphragm, they dive into the urogenital diaphragm to go and supply that whole area that is called the what? The perineum. So the role, so there we can see, not too long with these, you know. So there we can see now, and we're looking right here. Blow it up. And there we can see that from S234, see it here? That's L5, S1, S2, S3, S4. But by the way, you notice how the difference in the size between these nerves here, right? Look at how big and powerful we are here. And when we get down to S4 is not a very big nerve, you know. And then S5, look at poor little S5. Very, very tiny down to what? Coccygeal. Okay? So there you can see now that from L234, we will see that's the pudendal nerve. And there we can see the internal pudendal artery, the pudendal nerve, and we see it over here. So this is now looking with bone superimposed, right? So that's the sympathetic trunk. These are the anterior sacral foramina. These boys are going to form the ganglion impar, and there we can see the pudendal nerve, okay? From S2, says S1, S2, and then we see between L5 and S1, the superior gluteal artery. Between S1 and S2, we see the inferior gluteal artery, and then traveling now below S2, we see now the pudendal artery, right? See the pudendal artery, and from S2, 3, 4, we see the pudendal nerve, okay? Now, Crystal, that pudendal nerve is heading to the perineum, okay? There we can see now the lateral wall of the pelvis. Okay, so the lateral wall of the pelvis that we're doing, and very important is to watch. Look, watch what is happening to the ureter, and hold and see the multiple branches of the what? Of the anterior division of the internal iliac, right? The multiple divisions of the anterior iliac. There we see the ovary lying in the ovarian fossa. See the ovary right there? And then the nerve. What's the nerve now that is traversing the ovarian fossa? What's the nerve that's traversing the ovarian fossa? And that nerve is the obturator nerve. Howship-Romberg sign. So any disturbance of with the ovary, like ovarian cysts or anything like that, patient has pain right down the medial aspect of the thigh to the knee. Right. And I remember I had a friend of mine, very nice lady, you know. I carried her from one point to another in the country. And she was saying when we were driving, you know, the girl I feel this pain. She was like just a pain along the medial aspect of her thigh and going right to her, to the knee. And we'll give her a chance. That was a classic. She had ovarian cysts. Sorry, I'm in a class. I'm teaching. Sorry, I'm teaching here. I don't like to shut up. No. Yeah, I'm just, sorry, I'm in a class teaching. Call me at about 1 o'clock. 1 o'clock, all right? Please. Good. Give her a chance. See, that was very nice. Because, sorry, you just, I'm in a lecture and then I just did it. Okay. Good. Okay. Right, so there it is. She went to the Mandible Hospital and they did what they had to do. So she had classic Howship-Romberg sign. Very sad to her. You know how she died? How do you think she died? Somebody got into a quarrel with her in the country, took a cutlass and off with her head. So she died in a battery. Off with her head. Good or a bad story? Hey, well, good story. Be a good story. That's sad, isn't that so?
Very sad.
Yeah, chop off the poor lady's head. It was a nice lady.
I'm sure.
But there we see. See, I've shown you this one. Crystal, look at this here in their heart. So there is the ovary. See the ovary right here? And there you can see the fallopian tube. There you see the mesovarium. See the mesovarium is right here. That's the mesovarium. This is the broad ligament. And there we can see how the fallopian tube is winding around. Maybe this boy is a fimbria ovarica. Then look here where the magic is. Look at these powerful things like big NWC pipes you see up in the mountains. No. Give a chance. So there we can see, we're having fun. So there you can see the what? That's the common iliac artery. See this boy here? That's a common iliac. This boy, this powerful big pipe here is the external iliac. This big pipe here is the internal iliac. And there you can see the ureter just slipping over the external iliac. Yes or no?
Yes.
And then now slipping on with the anterior medial part of the internal iliac. What is this tissue right here? What is this tissue right here that's been cut? What did we cut off to show all of this here? What did we cut off to show all of this? This tissue right here. Crystal, look over my shoulder, sweetheart, and look at what is this tissue right here. That's peritoneum. right? See, they strip the peritoneum here, right? Now, when you do ONG, you're going to find that when they get ovarian cancer, right, which is either formed from, may even be generated from the germinal epithelium, there is going to be a transperitoneal movement. So once you get cancer of the ovary, which is too late, it starts quickly to spread. And it's a transperitoneal spread through the lymph nodes, etc. But it just starts to migrate all through into the greater omentum and all over. Okay, so my best friend, one of my good friends, beautiful girl, right, never got married, still young, still beautiful. Her funeral program is right in my drawer where I took these keys out from. Pretty girl. Went to see her. As I told you, right, she lived right beside Suffering. So I went to see her, and we went with three doctors. I went to see her, you know. 3 doctors I went with, and it was for Christmas. And I told her she was right in front of me. And tummy was big. She was always a very, but its abdomen was distended. Went to the doctor, you know, she said, her stomach is distended and she's feeling bad. Listen carefully, you know. And the doctor prescribed her stomach medicines, right? And said she must try, and then she says, she's getting abs machine. She pointed right over to that young lady. See her little abs machine? But when I was leaving, I said, you know, Crystal, I don't like how her abdomen is looking, you know. It don't look like a normal thing. So then I'm coming around the corner. Say her name is Joan. I said, Joan, do you mind if I touch your abdomen? She says, she told me, I said, don't, go ahead, Mike. So I didn't, forgive me, I can touch Crystal. When I touched it, it was tough like a football. This is very strange. You know, so, no soft fat there. So I then asked one of my consultants that I know to see her the next day. Blam. By next day, she was diagnosed with ascites and ovarian cancer. Right. Then we did the CT. They found out her greater omentum was all coagulated and became like a cake, omental cake. I then spoke to Dr. Laws, who was there. I said, Dale, she has omental cake. And he said, Mike, that's a death sentence. Right? And I went through with her with it, and in no time, the ovarian cancer took her. The doctor did not examine her. And at the same time, she was attending also, she had been to an ONG specialist, you know, who did not do all any tests and all. I don't want to mention the name of the ONG man. Big recognized man. Died ovarian cancer. So I always tell the females, my good friend quickly, she's a Chinese friend of mine, mother. See her lovely picture in the living room there. I said, so David, how did your mom die? At 87, ovarian cancer, 87. So when they're taking out to do a hysterectomy, once the woman is after menopause, they should take the ovaries too. Right? Because those ovaries are going to serve no purpose after menopause, and they right till you, they are now a source of trouble. So once they finish with the ovaries, then get what? Get rid of them. You Patrick? Get what? Get rid of them. Don't tell him they must get rid of A, B, and C. Right? Your mom. Right, so there, so transperitoneal. But there you can see in the ovarian fossa. And then who is this man here? Who do you think this boy is here? That's the external iliac. That's the internal iliac. That is the ureter crossing right over it. See the ureter coming down right here? See the ureter? Then who is this big boy right here? Big boy going, and we can take a dot and project the line right here. Who is this big boy right here? You can see it on the screen? I don't know, you know. Let me see. Yeah, see the big boy? Who is that big boy? The common iliac, external iliac pipe, like a big NWC pipe, and then that's the internal iliac. Okay? Crossing over the external iliac, and then coming in relation to the internal iliac. Who is this big boy right here?
Obturator nerve.
Obturator nerve, 300 marks. Perfect. Right. There, so we see another one here quickly. So we're having fun, you know. So there you can see the piriformis, yes or no? Yes. And there we see the inferior, the internal pudendal artery, and the pudendal nerve. Now that nerve is going to divide up. Tell me about some branches of the pudendal nerve. So actually in Alcock's canal, we don't really find the pudendal nerve, you know. It's already divided up. But for your sake, it hasn't divided up. If you're doing postgraduate work, it has divided up. Okay, so what are some branches we're going to find? So we're going to find the pudendal nerve giving the inferior rectal nerve. Yes or no?
Yes.
The sphincter ana externus that you have continence, right? It holds this anal canal closed, shut. What else are we going to find? The perineal branch, which is the largest branch, that's going to supply all the muscles in an area called the perineum. Then we're going to find dorsal nerve of the penis, dorsal nerve of the clitoris, and then we're going to find the posterior scrotal nerves and the posterior labial nerves. Okay, there. Okay. Here now we are looking at the perineum. You must always remember the orientation, right? So the orientation is very, very important. So you understand. See how you have to understand here? So Crystal, very important in your patient. This is what you have to understand. That the ASIS and the pubic tubercle are on the same vertical plane. So the ASIS and the pubic tubercle are on the same vertical plane. Therefore, the urogenital diaphragm that is going to fill up the pubic arch. See, this is a female. This is a female pubic arch, right? The male can just about get in 2 fingers. The female can get in 3 fingers. And I don't mean to be, well, you have to see what you're going to have to do when you're going to be an ONG. You can actually, and you can see the fist can pass through. So sometimes, you know, when the female now is expelled, sometimes the ONG guy has to take his gloves and then go right in and clean out. He will just go right in there. It's unbelievable, right? It's unbelievable. Right into the uterus. And the gloves, and he's taking out the placenta and just goes right sometimes behind and just pulls everything out. Okay, so you can see, you can get right through there. In the male, you can't see. This is a male, you know. Look here, watch. Boom. See, I can't get in at all. Look there. See the male? And the pubic arch can basically hold 2 fingers. In a female, look. Boom. Right in. Okay, so you're going to have to do that sometimes. When there's bleeding and all of that, boom, you have to pack whatever you're doing down there, right? There's a rough story. No. Also observe that the diagonal conjugate, see how I can't meet the what? I cannot, my fingers, so the ONG guy has his fingers measured, you know. Right after pregnancy, you're going to have to do an examination, and he's going to just see if you have a competent pelvis. I can't reach. See, I can't reach. In the male, well, of course, no, sadly, I've put everything here, but if I put my finger right through, boom, I just easily reach the sacral promontory. So the female has the diagonal conjugate is very long, okay, about 11.5 to 12 centimeters, right, from that region. But what I want you to understand, look here, Crystal, is that the UG diaphragm, this is how the pelvis, so the perineum, the part, perineum is a diamond-shaped space, we said, divided into an anal triangle, yes? Yes. And a urogenital triangle.
Right, no, we're not seeing it, Mr. Barton.
Yes, so there you can see, so that's divided into the anal triangle and the urogenital triangle. Reasonable? But what I want you to see clearly is that the urogenital diaphragm is in a horizontal position. So there below there, look at this lamp. You see how this lamp is hanging down? And it's hanging down from the roof. We can imagine the roof is a perineal membrane. Look at the roof, that's the perineal membrane. The inferior aspect of the UG diaphragm. Then the space that we're in here now is the superficial perineal pouch. So, the superficial perineal pouch is in a horizontal plane. So the cleft between the labia majora is an anterior posterior cleft, the pudendal cleft, right? So everything is there. So when one is examined this way, she has to go into the lithotomy position, and the legs are put up on a stirrup to be able to examine the what? The perineum. But the urogenital, it's really there. And in the male, everything is just hanging down, right? Everything is just hanging down, okay? So you'll see here now that. So we're looking, the patient is in the lithotomy position, okay? And there you can see now that they've dissected off, and that structure is a perineal membrane, okay? Now we want to see if this is a male or a female. Well, obviously it is a male, isn't that so? Why? Why is this a male? There's no vagina. There is no vagina, okay? All we can see piercing the perineal membrane. See the perineal membrane? And that's where the dorsal vein of the penis is passing through, in between the arcuate ligament and the transverse perineal ligament, okay? And there you can see the perineal membrane. They've kind of cut some windows into it that you can see the pudendal nerve, and this branch that is coming here, these are some perineal branches, but that's the dorsal nerve of the penis, okay? The dorsal artery to the bulb and all of that sort of stuff. And there you can see winding over. Those are the pudendal what?
We can see
Nerves and vessels, okay? Now, there we're looking now, sorry, at the male, because Crystal decides. So there we're looking at the male, okay? And let's just have fun. There you can see the urinary bladder. There you see the puboprostatic ligament. What's the name of that ligament? Puboprostatic ligament. There you see the prostaticovesical venous plexus. See the prostaticovesical venous plexus here, right? And there you can see the utricle. See the utricle, yes or no, Crystal? Crystal, you see it? That's the utricle. Then there you see the urogenital diaphragm. See the urogenital diaphragm? It's the muscle Dr. Ledenque pointing out, the rectourethralis muscle. Yeah, rectourethralis muscle that you see right here. That's the UG diaphragm. That's the superior fascia. That's the inferior fascia. And this is a space to permit the what? The passage of the dorsal vein of the penis. So there you can see now that that is Colles fascia. So this area here, that is in the superficial perineal pouch. And you see that Colles fascia comes back and is attached to the posterior border of the UG diaphragm. So this area is the bulb of the penis. Yes, right, Crystal? That's the intrabulbar fossa. And there is the penile urethra coming down here. And if you zone in, fill up the screen with this part here. Just fill it up hard with this part where I'm touching. Right? Excellent, my beautiful. And who is this Crystal that I'm pointing at? The navicular fossa. So remember this. Look, see, it wrote it very nice, RP. So you're not going to pass the instrument, you see? You can't place the instrument paste up like this. You'll get into there, so you have to paste the instrument down like that, and then traverse, and then you're up into there. Reasonable? Right, so there you can see that's a penile urethra. Okay? No. This specimen is very important. This is a coronal section through the what? The male pelvis. Our characters, urinary bladder, prostate, right? Who is this muscle hanging down here? Levator ani. Levator ani is going to be attached up here to who? As he's coming across, who is the levator ani attached to here? A tendinous band. What's the name of that tendinous band? The arcus tendineus. Right? The arcus tendineus. Okay? And there is the levator ani sloping down. So watch here, Crystal. The urinary bladder, the inferior lateral surface of the urinary bladder are related, 1 to the levator ani and 2 to the fascia of the obturator internus. So it will have obturator internus and the levator ani. But the prostate, which is an inverted pyramid, what is the apex of the prostate related to? Who is this guy right here?
The UG diaphragm.
That's the UG diaphragm. In the lecture, what did I compare it to? In the lecture, Hmm?
Or hamburger or something.
Can you still see the girl eating the hamburger? Yes or no? Yes or no? You don't remember the lecture?
Can you show us again for those who forgot?
No. Did any of you attend the lecture?
PowerPoint.
So do you remember the girl eating the hamburger? Yes or no?
Yes. Not even in the picture. Wait, what?
What you notice about her hamburger?
Very meaty.
Very meaty like this, right? Good, right? Biting in. Okay? So this is a hamburger. And there you can see the bread above and the bread below. That is the superior fascia of the UG diaphragm. And you notice that the inferior fascia is far thicker. Okay? Because these structures, look, see these structures here? Look what they're hanging from the perineal membrane. So what structure is now going to be attached to the perineal membrane and supported by the bulb of the penis? The what? Bulb. The crura are attached to what? To, what is the name of this bone here? What is this bone here name? Right here. What's this bone here name? What's that bone name?
Tissue.
Correct. Conjoined ischiopubic rami. Right. What is the angle, the pubic angle in the male?
Less than 60.
Right? Correct. 300 marks. So 2/3 of a right angle. 60 degrees. In the female, ooh, it's wide. So what degree? Like about 90, going up to even about 120. Okay? And similarly, look at the female greater sciatic notch. Very, very, very wide. Okay? Okay, relax. Male, apex of the prostate in relation to the superior fascia of the UG diaphragm. Base in relation to the neck of the urinary bladder. The uvula of the bladder. See the uvula of the bladder right there? This is sometimes what can, that's a median lobe, Patrick, that can block the internal urethral meatus. No man, you're going to get this. You can take pictures of it
I
after, you
wanted
know.
to get it before so I can leave it while you're talking.
Okay, go on.
Oh, thank you. You're so sweet. I can just do these in the meantime and just send it to everybody real quick. So
Okay.
everybody has it.
Take them. All right. But keep them in order.
Yes, sir.
So their number, this is the 8th. Right? So there you see the superior fascia of the UG diaphragm. There we see the inferior fascia. Crystal, look hard, sweetheart. Bulb of the penis. Intrabulbar fossa. The bulbus spongiosus. Right? Exiting the last few drops of urine or semen. What's the name of the muscle in the urogenital diaphragm of the male, Crystal? Sphincter urethrae. A massive amount of muscle. Sphincter urethrae. Reasonable? Right? Voluntary control, perineal branch of the pudendal nerve. And there is the crura of the penis, surrounded by the ischio cavernosus. And there we can see now some posterior scrotal nerves and vessels there. Reasonable? Very good. Male. Okay? And there we can see the root of the penis. So in the superficial perineal pouch, so one sec, the area between the superior fascia and the inferior fascia of the UG diaphragm called the perineal membrane, that's called the deep perineal pouch. Name me all the things you find in the deep perineal pouch. Go through. All the things you find in the deep perineal pouch. Male.
You find
Traversing it will be the membranous urethra.
the
Bulbourethral glands, corpus glands.
you find the deep transverse perineal muscle.
Very good, going into the perineal body.
That's not like
And the sphincter urethrae. Look at it, look on this, the bulk of it is sphincter urethrae. Right? And you're going to find nerves and vessels. The internal pudendal artery with branches coming off of it and the deep dorsal nerve of the penis. And some perineal branches. Yeah? That's in the male. Okay? And then note that the ducts pierce the perineal membrane. Corpus glands become infected with gonorrhea sometimes and drain into the penile urethra. Crystal, look hard on this here, sweetheart. So focus on this hard. This whole apparatus is called what? Or what is a collective name to all of these boys here? What is a collective name to all these boys?
Triangle.
Root of the penis. Right? What's another name for root of the penis? Radix. What's another name? Bulb surrounded by bulbous spongiosus and a secura attached to the everted edges of the conjoint ischiopubic rami. And there you can see the deep dorsal vein of the penis, and there you can see the superficial one. Okay, so we look again. One second, look again. There you can see surrounded by the bulbous spongiosus and surrounded here the cura by the ischiocavernosus. Then now there will be a thing around the penis like that they ask in your UG exam, you know. What is the thing that forms a loop around here? That forms a loop around here. What is the name of that loop? The fundiform ligament. Right, Patrick? Fundiform ligament. Right? The fundiform ligament. Right? So well developed, like in horses and dogs and all of that, where you see the male organ is kind of applied to their anterior abdominal wall. Right? Okay, in us now, it's not applied like that. You don't carry it around like that. Yes or no? Definitely not. Okay, very good. Very developed fundiform ligament. However, attached to the linea alba now, and so coming down is the suspensory ligament of the penis that Dr. Long will deal with. You've heard about Dr. Long, right? Okay, so he will, if you're having any problems in a certain department, his office is on Slipen Road, right? You go to Dr. Long, he'll arrange an operation. He usually operates at St. Joseph's Hospital, right? And he will cut the thing for you, right? And then you'll get marvelous results after. Really will be happy with you. Right? So we move into the female. All right. So we're looking here now at the external. So the female, remember now, the female we have in a lithotomy position. Okay? So this is it. So we had the external genitalia of the male. Where is our male? Give a chance. Oh, this is our gentleman. See our gentleman there? Yeah? Now we have a lady. Okay. So female there. The whole of this area now, relax, is referred to as the vulva. So the external genitalia of the female is referred to as the vulva. The scrotum and the labia majora are developed from the labioscrotal swellings. So this here is going to be skin. That's sort of a bit specialized, right? Right? And that's the labia majora that we see. Up here it has an anterior commissure, and down here it has a posterior commissure. Okay? So that's the posterior commissure right here, and that's the labia majora. See the labia majora fat fill? Okay, so they're fat fill, right? And it comes up just over here, and that area is referred to as the anterior commissure, which is going to be in continuity now with a fat fill space known as the mons pubis. Okay, there's the mons pubis. Now the slit in between the labia majora, that's referred to as the pudendal cleft, right? The pudendal cleft, or the vulval slit. The vulval slit or the pudendal cleft, okay? In between the buttocks, that's referred to as the natal cleft, okay? Now, right in this area, right here, look here, right here, right at this point right here, so the anus is here, right at that point is where we're going to get the perineal body. So coming across like that, right across like that, you're going to see some muscles coming right across like that. And those are the transverse perineal muscles. So right on the line right here, Krista, will be the superficial transverse perineal muscles. Looks carefully. So in between the two labia majora is what is called the pudendal cleft. Reasonable? And then now, when we open up the pudendal cleft now, we're going to see now the labia minora. So these are erectile. Okay, so composed of erectile tissue. Now where the labia minora now comes together, back right here, that is referred to as the fourchette, right? So it's a little important little membranous area that is going to connect the two areas. So when they're the patient, when the person in a criminal case, like has been raped, right? The forensic people and the thing, they're going to look for a tearing of the foreshed. Okay? So where the labia minora meet posteriorly, there is a foreshed. And just in front of that foreshed, and just separating it from the introitus of the vagina, that area is called the navicular fossa. So the males have a navicular fossa, and the females have a navicular fossa. And the navicular fossa lies just anterior to the foreshed. This is sometimes called the posterior foreshed, but you don't know, it's really just the foreshed. Foreshed comes from the Italian word for fork, right? It comes from the Italian word. Foreshed is from fork, okay? That's the navicular fossa. And then now, so this right here is going to be the posterior commissure, and right here will be the perineum. So in a childbirth that is going too much, I mean the fetal head is going too much, if the ONG person is not there, it will tear right directly into here. Okay, so the first thing to tear is the foreshed, okay? And it will tear right through that posterior commissure and tear into the anal canal, okay? So I have had colleagues who have gone and worked in some country hospital. They say, boy, Mike is rough. Because sometimes when the little baby is being born, even they don't have proper lighting. So don't have lighting, you know. And the poor ladies, ladies delivering, and things are going bad, and it's just tears. And they said sometimes you're looking straight into the anal canal, right? Just tears right into the anal canal. So that's very sad, okay? So even this is, the lighting is very poor, you know? So what they will do, as Dr. Barnett sat right over there and told you, they don't want a tear, because what he pointed out, very interesting, is when it's a rough tear, it's hard to what? For the surgeon to know, repair that tear. However, if he does a 5 o'clock or a 7 o'clock, and away from the perineal body, 5 and 7, because the integrity of the pelvic diaphragm, and Dr. Ledenko was saying there are 10 muscles, Gardner was saying 9, Dr. Ledenko added that 10 muscles that goes into the perineal body. So the integrity of the pelvic diaphragm is dependent on the what? The perineal body. Reasonable? So right here, so the gynecologists call this the perineum. The gynecology is where the perineal body is, okay? Now when we trace the labia minora anteriorly now, all of this is going to be related. The labia minora is very interesting. In the male, you know, is going to be related to the development of the membranous urethra. I mean, sorry, of the penile urethra, okay? And its closure where they have a hypospadias and all of that sort of stuff. So sometimes, right at the hospital, right now, there is a consultant that I taught, and she's Dr. Dundas. So who she got married to, Patrick? Dundas. I can't remember her last name. Dundas Biles. So she now took over from Duncan. So she's the head. So I asked my students, you know, we're passing through there, what are you doing now? A lot of their time is spent correcting babies with hypospadias. So hypospadias is a common thing for them to, you will see, Crystal, you'll be up there. So sometimes the urethra may open way, way back, right in a perineal region, right? And fail to traverse the thing. So you have different types of hypospadias, and more rare is epispadias. So the development of this area is very, very interesting. So if you know, Dr. Thomas Snow last year asked about that structure. So he has some dissected specimens and all of that, and he just lays them out like that, right, Patrick? We remember the very table they're laid it out. So he has a number of these structures, vulvas, right? Reasonable, he's the vulva man. Okay? We are the stomach people, right, Patrick? What the hell is it? So there now we say the labia minora, and then now that labia minora is going to be dividing into a frenulum, and then for hood of the clitoris. Okay? And there we can see the hood. Now once you separate the labia minora, right? As you're going to do a colposcopy, right? Are you passing the speculum there? You then, this the area in between the labia minora now, that area is referred to as the vestibule of the vagina. This whole area is referred to as what? The vestibule of the vagina, between the labia minora. Remember, it's going to form a hood over the clitoris, and there we can see now the frenulum. So posterior scrotal, posterior labial nerves are very much involved with innervation here, yes? All of this area, if there's any malignancy of all this area, where is it draining to? Lymphatic drainage is to where? To the medial group of superficial inguinal nodes. Any problem here, medial group of superficial inguinal nodes, right? You're going to find a lot of females coming, young females coming now, once they become sexually active, sometimes you see them now coming now with swellings right here. And that is referred to as a Bartholin cyst. Okay, Bartholin cysts are very, very common. Okay, or in all, so the Bartholin cyst. Okay, and that's what the gynecologist has to deal with. And there we can see now that opening right into the vestibule there. That's the clitoris right here, the glans clitoris. That's the external urethral meatus, and then opening right beside here will be Skene's glands. Okay, Skene's glands. And opening, and I'm going to show in the specimen, opening right here will be Bartholin's glands. Okay? Right.
Just reading back, just show them when you're going to pass the speculum.
Where do I get the specimen?
Okay.
You're right. So I'll ask Dr. Ledenqui to do that. So there you can see now, there we can see now, this is the what? The female. And there you can see the superficial perineal pouch. Remember, those two things are not connected in spaces, because three fascias seal off the area between urogenital triangle and anal triangle. Three fascias seal this area. Nothing can go, nothing comes here to here, nothing goes here to there. Right? They're sealed off. What seals it? What are the three things that seal it off? Perineal membrane, Colles fascia, and superior fascia of the UG diaphragm. And remember also, it's attached to the everted edges, right? So Scarpa's fascia continues down into this area to become Colles fascia, okay? And there you can see the female right here. So they've dissected off. So what was there, Crystal? This is this, right? So we now remove the skin and on the overlying fascia, and we open up the superficial perineal pouch. So there we can see now the superficial perineal pouch of the female opened up. Okay? And there we can see the glands, the clitoris, which has the crura, a bulb, a shaft, and the glands. Okay? Right? And the clitoris is, when I show you on the specimen, this is an elderly lady. The clitoris is a very large structure. You may think it's a small structure, it's not. It's basically what's happening is that the bulk of it is what? Hidden. The males are not hidden. You see everything with the male, right? Yes or no? Yes. With the female, you just see just the tip of the iceberg, right? There you can see that, and there they also have the issue cavernosus to help once the clitoris becomes engorged, right, with blood, to keep that there. And there we can see now that the bulb. So we have a bulb of the penis, but because the vestibule of the vagina is there, it breaks the bulb into what? Two parts. So it's now called not bulb of the clitoris, but bulb of the vestibule. There's a lot of controversy, right? And it's still, I would like to do even a little research on it, because some diagrams and some people show it may be shown in, you see in this diagram here, if you look at this diagram here, you see here, watch here now, commissure of the bulb. And you see some erectile tissue continues here, Patrick, and continuing to a kind of a glans portion. But it's said that the female clitoris just has the two corpora cavernosae, right, of the continuing, right, two erectile cylinders. but there may be. So I will have to do some dissection. I'd like to do some histological sections through it to see what is really happening. Where is that? Oh, that we gone with something? Very good. So yesterday I went and got these prepared, you know. When did I get them prepared? Yesterday. Now there's a man, he does his preparation. Where did I go to? Hot off the press. Right, so I carried some of my, so one of the greatest anatomists in University of Edinburgh, while that school attracted so many people, trained nearly everybody, was a man called Jameson. And Jameson prepared all these drawings. I have his book. I took these diagrams out of the book. Went yesterday there. And what time do you think I left out of the press? 6:15. Nearly the last customer in there. And when the man says, "You want all of these today?" I say, "Yes, have a class tomorrow." And when I got them, because you know they have to laminate them when they're hot, I actually got them hot. They were actually hot in my hand when I got them.
No way.
You know. I said, "Whoa, see why you play all the place out of the press." Yes, so here's the fun. But I use them, we'll also use them for teaching the surgery residents, right? Yes, so there we can see the crura. I had some, you know, but they weren't so great. So I decided to do new ones. So there you see the crura surrounded by the ischium cavernosus, and there you can see the bulb. So all this area around, so when a female becomes sexually excited, all of this area becomes very engorged, right? And the temperature, so they have looked at a female when she's sexually aroused, and that temperature around there becomes quite hot, okay? Very dilated, distended with blood, and the temperature rises quite high, okay, in this whole area right here. And this area becomes all there. So there we see the bulb of the vestibule, right? The bulb of the vestibule. And there we can see hidden under here the bulbourethral glands. See the bulbourethral glands? And this is the hymen right here, right? And there we can see the urethra, okay? And there we see the clitoris right here, okay? All right. Then now we look at the last one is a frontal section. So where's the frontal section of the male? Crystal, find the frontal section of the male for me, Lord. Yeah, like, yeah. Yes, there. Excellent. So compare the two. Yes, so compare the two, right, Patrick? Compare the two, right? So what I want you to see, Crystal, is that the pudendal cleft, see the cleft right here, going right in? This is an anterior-posterior cleft. Reasonable? Okay? So there you can see the cleft. So there you can see the superficial perineal pouch of the male, containing the root of the penis. And there you can see now the superficial perineal pouch. Examine it carefully. So focus hard down on this now, you know. So there you see Colles fascia. Then all of this, so the labia majora, there is all subcutaneous tissue, right? So see there, that's the labia majora right here. That's the pudendal cleft right here. See the pudendal cleft? And then once we get up into here now, this is the what? The vestibule of the vagina, right? So when the female is in there, you're going to be examining now carefully what is happening in the vestibule of the vagina, okay? And there you can see now the bulb of the vestibule. See, it's surrounding a bit of the vagina right here. And there we can see the bulbourethral glands and where they open the ducts. And there we can see now the crura of the clitoris, okay? And there, as you see, the glands are opening into the superficial pouch. But there is a superficial pouch of the female, and now that's the deep perineal pouch of the male, of the female, sorry. So Crystal, what will you find, or Guthrie, what do we find in the deep perineal pouch of the female? Guthrie, look at it. So focus hard on that now. Just fill this up here. So what you're going to find in the female, in the deep perineal pouch of the female, okay? Well, the first thing is the vagina is going to be traversing it. Reasonable? Right. And then now it's going to be a hamburger. There's meat in there. Okay? So what is the meat that we find in the female? What's the name of the muscle?
Sphincter urethra.
That's the sphincter vaginae. Okay, reasonable? Alright, so that's the thing that's going to contract down on the vagina. Okay? So we won't go into all that bangaranga, but there's something called the art of lovemaking. The art of lovemaking, what the hell is that? One day you'll find out. The art of lovemaking. Reasonable? But the females know when the male is doing A, B, and C, and the female is doing X, Y, and Z. So the female knows how to use her muscles. One day you will go there. Just relax. One day. Right? One day. And she knows how to use her muscles and make everything great. Reasonable? And the guy knows how to do his business. He's there, look, there. He also said like that. So already, but there. So the problem now, as I said, is after childbirth, that muscle becomes all the vagina distended. So therefore, they do their exercises. Okay, to what? To bring back the tone in the muscle. Okay, so just relax. So in there, just to say, we find the sphincter vaginae. I'm trying to in little ways to help you to remember too, so you won't forget that. What's the name of the muscle? Sphincter vaginae. Okay. Now the sphincter vaginae is also going to encircle the female urethra. Whereas in us males, we have sphincter urethrae. In the females now, some of that muscle is going to encircle the what? The urethra. Okay? What other muscle we're going to get in there? In the male and in the female? The deep transverse perineum. The what? The deep transverse perineum. Then you're going to find the internal pudendal artery in there, and you're going to find some perineal branches of the pudendal nerve to innervate those muscles, isn't that so? And then also you're going to find this nerve right here now, that's the dorsal nerve of the clitoris, okay? The dorsal nerve of the clitoris. So one of my top residents in England, right, he did so well, he went and he's now like at the apex of his career in England. Big articles coming out on him in England, Caribbeans graduate, so. So he's got all FRC top prizes and doing very, very well. And he always keeps in touch with me, right? And I'm so proud of all he's doing. Then now he sent me now, they did know just recently, and I wanted to print the picture yesterday, but the people at Hot Off the Press were getting upset with me. But they've done now a fantastic thing on the study using special kind of radiological imaging to now image all the nerves on the clitoris, right? And it's a fascinating thing to see, right? They found that there are about 10,000 nerve endings on the clitoris, right? So the clitoris is far more well endowed than the male, right? Okay, the female is what? Far more. So us males think that we run the things, We don't run a damn thing. Forget it. The females are way ahead of us, Poor Tom Jones, after I think that he dead and gone, and he gone to bed dead. Reasonable, right? And the lady, if you want, she can go on till the very next day. Reasonable? All right. And they found out very interesting that in the brain stem, listen to it there, that there are the centers, they're orgasmic centers. Okay? So when I'm teaching the psychiatry residents, I have to teach about that. Okay? So some females, there are centers there, but in some females, rarely they can't pick up a center there. So some females, these are rare females, they're non-orgasmic, which is sad, so they never reach an orgasm. Okay? In some females now, there are a number of centers, and these are females who are multi-orgasmic. Okay? Reasonable, they are on top of the what? The world, right? But poor Tom Jones, after one or two times, he's fatigued. They're retired, gone to bed and snore. But the women are so the women are designed very different to the men. Just want you to know that. So the females also have in there the deep transverse perineal muscle. But I wanted to print this diagram to show you because it's a fantastic diagram showing all the nerves and vessels, the nerves, especially the nerves, because he's a man into the nervous system. Okay, so we have looked at there. Now, just to look there, oh, Crystal, you weren't here last time, love. So there is the thing. So remember now, watch here now, come and zoom in hard on this. Okay, so this now is the urogenital diaphragm. So where are we in the perineum of the male? What have we opened up? Let me say, Guthrie, this is a man. Okay, so what have I? What am I? Where am I now in the male? In the? I'm in the superficial pouch. What have I dissected off? Colles fascia, right? What have I dissected off? Colles fascia. So watch here, Crystal. This is in the what? This is in the superficial perineal pouch of the male. There is a crura of the penis attached to bone, reasonable. And the male, the ischiopubic rami in the male is far more well developed than in the female. Okay? Because the male has to anchor the penis. Okay? The penis has to be well anchored. Okay? Right? And he's surrounded by muscle, and the muscle is the what? The ischio cavernosus. To maintain the erection. Isn't that so? Go through it. You don't want to be a disappointment. You don't want to be a disappointment, man, no, you know. Yeah, that, no, I'm trying to see the young man we have to educate him, right? Very good. Very good. No disappointment, man. Okay. Then there is the bulb, reasonable, surrounded by the bulbo spongiosus. There we see two little ducts for the what? The bulbourethral glands. There we see the superficial transverse perineal muscle. Right? As you see it, going into the perineal body. So remember, we're going this way, so we can reflect that. And then when we reflect now, see, so this, when we take off these boys and take off the root of the penis, when we remove the root of the penis and everything, who are we left with? No, who are we left with? I've dissected off the what? This thing, right? And there, who am I seeing now? Who is this? Perineal membrane. Right, so I've dissected off the root of the penis, and I'm left now with the perineal membrane. You see that there, Crystal? Yes. Then now, if I open up the perineal membrane, I'm now in the what? In the deep pouch. Right? And I'm in the deep pouch. And I see it's a male, so it's the urethra is here, right? All of this in green. So that's the urethra. All of this in green is the what? Sphincter, urethra. And then we see there's a muscle back here called the deep transverse perineal. And there are, who are these boys? Urethral glands, right? So they may be infected in gonorrhea and all of these kind of things, right? And syphilis and all of these kind of stories. All of these glands here may be infected, okay? Then we now open up and then reflect this across. And who is this now? The superior fascia of the UG diaphragm. So superior fascia of the UG diaphragm, yes. Then we get now the muscles and glands. Then we get the perineal membrane. Then we're into the superficial pouch. Right? Excellent. All right. So we're getting places. All right. So very, very I must just show you the male for 1 minute and then the female. Okay? Very good, very good, very good, very good, very good. All right. Okay, by the way, sorry. There, oh gosh, Victor. Give it a chance. No, don't tell me I don't. You have to be very careful and put all these gloves in. Give it a chance. Okay. Relax. Right. So, it is very important, because for you to understand this area, right? Because you're going to have a lot of female patients coming to you. You need to know what is happening, okay? Right. So there we are now in the female, okay? Crystal, look hard, sweetheart, okay? Take a pointer. Hold this pointer. Okay? Touch for me the core of the clitoris.
Here.
No, remember it's attached to the ischiopubic rami. So all along there. Right? And you see it's covered by muscle, the ischiocavernosus. Superficial transverse perineal muscle. Touch the bulb of the vestibule. 300 marks. Touch the bulbourethral gland. This little boy right here. Right? And then the muscle that is surrounding the bulb of the vestibule, the bulbus spongiosus. See the bulbus spongiosus here? That there is the fourchette. That is the navicular fossa. Okay? So this is the labia minora on here. So there, that is the vestibule of the vagina. There is the what? The female urethra. Right. Okay, there is the glans clitoris. Now this is rubbish to make it this size, because I'll show you on this specimen, this is about 10 times larger than that, okay? Or this is just rubbish here. So there, that is there. But there we can see this is the vestibule, and there that area is called the introitus. Okay, that's the introitus right here.